Everyone's enjoying the conference, and I'm going to talk to you this morning about urinary malignancies. So let me share my screen and get to the presentation. Okay, we're going to start our talk out this morning on the solid tumor rules. And what I've done with that, instead of creating a 70 to 80 slide PowerPoint, which I know is torture to sit through, I've downloaded a copy of the PDF of the solid tumor rules and gone through and highlighted some of the major points. I do recommend, however, though, on your own time that you really go through and carefully read all of this, particularly the introduction and the equivalent terms and definitions section, because your normal habits as abstractors is to go straight to the rules and the histology chart. So if you're skipping over this information in the introduction, you're going to miss some pretty important points that you may not capture within the rules themselves. The group name urinary sites includes the renal pelvis, the ureter, the bladder and all of its subsites, the urethra, including the prostatic urethra and the paraurethral gland, as well as our overlapping lesion of urinary organs, C688, and urinary system, C689 NOS. In the United States, 90% of bladder tumors are urothelial carcinoma. Less than 5% are pure squamous cell pure squamous cell or adenocarcinoma. Flat urothelial carcinoma, our 8120/2 or /3, can have a widespread effect more so than our 8130, our papillary transitional cell carcinomas. The changes from the 2007 multiple primary and histology rules include when there's to code the most specific histology, whether from the biopsy or the resection. When there is a discrepancy between the biopsy and resection, for example, two distinctly different histologies that would appear on different rows in the histology chart, you will cut the histology from the most representative specimen or the greater amount of tumor. As far as the histologies go, there really are no significant changes or additions of new histologies to the histology table. So that's something we can be kind of glad about. Equivalent or equivalent terms. Flat transitional cell carcinoma is another name for transitional cell carcinoma NOS, the 8120 code. So you can have flat carcinoma, that would be the 8120/3, and the flat carcinoma in situ would be your 8120/2. Non-invasive may describe either in situ papillary carcinoma or 8130/2 or flat urothelial cell carcinoma 8120/2. Tumor mass, lesion, and neoplasm are all equivalent terms for determining multiple primaries only. Do not use these terms for case finding or for determining reportability. Urothelium, epithelium, and transitional epithelium are all equivalent. Terms that are not equivalent: phenotype is not equivalent to subtype, type, or variant. Non-invasive papillary urothelial carcinoma is not equivalent with flat urothelial carcinoma. Non-invasive is not equivalent to either papillary urothelial or flat urothelial carcinoma. Both TA and TIS tumors are technically non-invasive. Code the histology specified by the pathologist. So for coding primary site, we have a priority list to refer to. So just as you do when you're going through the rules, when you go through these instructions for determining primary site, you would stop at the first instruction that applies. First in priority, code overlapping lesion of urinary bladder C678 when a single tumor of any histology overlaps subsites of the bladder, or B, a single tumor or discontiguous tumors, which are urothelial carcinoma in situ. This is 8120/2 only. This does not include 8130/2. 8120/2 and involves only bladder and one or both ureters. No other urinary sites are involved. Second in priority, code bladder NOS C679 when there are multiple non-contiguous tumors within the bladder and the subsite origin is unknown or not documented. Third in priority, code overlapping lesion of urinary organs C688 when a single tumor overlaps two urinary sites and the origin is unknown or not documented. This includes renal pelvis and ureter, bladder and urethra, and bladder and ureter, except for the histology of 8120/2, which you would apply the instructions from number 1 up above. And fourth in priority for determining primary site is to code to urinary system NOS C689 when there are multiple discontiguous tumors in multiple organs within the urinary system. Next here, we have our primary site table that starts here and continues on to the next page. And I've overlapped something that I found a little puzzling, so I thought I would just bring it up here. For bladder code C679, if the tumor location is described as lateral posterior of wall of the bladder, and there's no hyphen between lateral and posterior, then you would code C679. If the tumor location is described as lateral posterior wall of the bladder with a hyphen between lateral and posterior, then you would code to C678, overlapping lesion of bladder, as well as if the tumor location is described as the fundus of the bladder. And then there's the rest of the table. So moving on to a discussion on histology, our table is laid out in the exact same fashion as the histology tables in the solid tumor rules for the other sites. So what you have is in column 1, you have the specific and NOS histology codes. The specific histologies, as you see in the second row, they do not have synonyms or subtype variants. The NOS histologies, as you see here in row 1, adenocarcinoma NOS, for example, they do have synonyms and subtype variants. The second column, the synonyms columns, have the same histology as the NOS terms in the first column. These are the preferred terms, and then the synonyms are synonyms that would have the same histology. The third column are our subtype variants. They have different histologies from their NOS codes. Also notice in the row with the sarcoma, that's the fourth row, you can have a histology that appears in both the NOS column and the subtype variant column, like you do for rhabdomyosarcoma. That is because rhabdomyosarcoma that you see listed in the subtype variant column is a subtype variant of sarcoma NOS. However, rhabdomyosarcoma is also listed as an NOS because it has subtype variants of its own that you see indented underneath the rhabdomyosarcoma in the subtype variant column. So there's the rest of the histology table. And I will mention, when you are trying to identify your histologies, that this table will be your first priority for identifying histology. If you do not find your histology in this table, then your next stop, second in priority, would be the ICD-03 implementation documentation found on the NACER website. So let's see, I thought I had that pulled up. I don't. Okay, to get to the NACER website, and I hope you're seeing my Google screen. Someone tell me if you're not. The NACER website is naaccr.org. Okay. Once you get to the home page of the NACER website, hover over Central Registry Standards, and then go to ICD-03 Coding Updates. When you click on that, the page there, you will see two different tabs. One for ICD-03.2. The ICD-03.2 is what you will be using for diagnoses beginning in 2021. So what we need to look at for now is in previous guidelines. And when you click on that, you'll see all the documentation that applies to diagnoses 1/1/18 through 12/31/20. So to get to your histology tables, you can click on either the PDF table that is sorted by numeric or alpha order, or you can use the Excel table. Whichever of those is your preference, you can click and download to your computer. And that is where you would look for your histology if not found in the histology table in your appropriate solid tumor rules chapter. The next in priority would be, if not found there, would be your ICD-03 manual. And if you do not find it there, then it is appropriate to send a question to Ask a SEER registrar. And in the histology rules that we'll get to in a little bit, you will see that there is a link to Ask a SEER registrar. You can also access Ask a SEER registrar by going to the SEER website. You should all have that one memorized, seer.cancer.gov. So when you get to the home page, hover over Registry Operations, and there underneath Questions and Answers, you see the link to Ask a SEER registrar. Our next table are non-reportable urinary tumors, and I highlighted just a couple because they may be the ones I think that you would see most often, and that is papillary urothelial neoplasm of low malignant potential and solitary fibrous tumor. And then going forward, you have the diagrams of the urinary system that you can look at on your own at a later time. So now we're going to move right into our discussion of the multiple primary rules. These rules are not used for tumor described as METs, and the timing for these rules is for cases diagnosed 1/1/18 going forward. And also, if you have a scenario where you have multiple tumors and one tumor was diagnosed prior to 1/1/18, and then you have a second tumor that's diagnosed after 1/1/18, and you need to make a decision as to whether that new primary is, as whether that second tumor is a new primary or not, then you would use these rules to help you make that decision. I'll just reiterate, when you go through the rules, the rules are hierarchical, and you stop at the first rule that applies to your scenario. So our first module is unknown if single or multiple tumors. Rule M1, abstract a single primary when it is not possible to determine if there is a single tumor or multiple tumors. And that is the only rule we have in that module. So that brings us to the single tumor module. M2, abstract a single primary when there is a single tumor. And that's the only rule in the single tumor module. So now we're moving on to the multiple tumor module. Separate non-contiguous tumors are always multiple primaries when in the urinary system and in a site other than the urinary system. Non-synchronous tumors other than urothelial carcinoma and urothelial carcinoma subtypes in multiple urinary sites are multiple primaries, and that would be, you'll see that in Rule M14. So moving on to M3, abstract multiple primaries when there are separate non-contiguous tumors in both the right and left renal pelvis and no other sites are involved. M4, abstract multiple primaries when there are separate tumors in the right and left ureter and no other sites are involved. M5, abstract a single primary when synchronous tumors are non-invasive in situ /2 urothelial carcinoma flat tumor. This applies to 8120/2 and not 8130/2. So your histology is 8120/2, and the sites are the bladder and one or both ureters. So this would be a single primary. No other sites involved other than the bladder and one or both ureters. M6, abstract multiple primaries when an invasive tumor occurs more than 60 days after an in situ tumor. So if you've already abstracted the case as an in situ case, you need to update the behavior to 3. And if the case has already been reported to the central registry, then that change of behavior needs to be updated there as well. M7, abstract a single primary when the patient has multiple occurrences of /2, that's in situ or non-invasive, urothelial carcinoma in the bladder. Tumors may be any combination of 8120/2 or 8130/2. This does not include micropapillary subtype. Timing is irrelevant. Tumors may be synchronous or non-synchronous. Abstract only one behavior /2 urothelial bladder primary per the patient's lifetime. M8, abstract multiple primaries when the patient has micropapillary urothelial carcinoma. This is 8131/3 of the bladder, and a urothelial carcinoma. That would be 8120 or 8130/3 of the bladder. So this is a new rule for 2018. M9, abstract a single primary when the patient has multiple invasive urothelial carcinomas in the bladder. Multiple occurrences of urothelial or urothelial subtypes, with the exception of micropapillary, or multiple occurrences of micropapillary. Timing is irrelevant. Abstract only one invasive urothelial bladder primary and only one micropapillary urothelial bladder primary per the patient's lifetime. M10, abstract multiple primaries when the patient has a subsequent tumor after being clinically disease-free for greater than 3 years after the original diagnosis or last recurrence. And we've gone over the definition of recurrence and the timing of recurrence in other presentations. So I'll leave the details in the notes to you to study on your own here. Rule M11, abstract a single primary when there are urothelial carcinomas in multiple urinary organs. This is only for urothelial carcinoma 8120 and all subtypes of urothelial carcinoma. This rule does not apply to any other carcinomas or sarcomas here. So this would be inclusive of your 8130s because those are subtypes of urothelial carcinoma. Behavior is irrelevant. This rule applies to multifocal, multicentric carcinoma, which involves 2 or more of the following urinary sites: renal pelvis, ureter, bladder, and urethra. M12, abstract multiple primaries when separate non-contiguous tumors are 2 or more subtype variants in the histology table. So you have seen this rule in the solid tumor rules for other sites. This is the same that you've seen before. M13, again, abstract multiple primaries when separate non-contiguous tumors are on different rows in table 2. You've seen that rule before. M14, abstract multiple primaries when the ICDO site code differs at the second and or third character of the topography code. M15, abstract a single primary when synchronous tumors or synchronous or separate non-contiguous tumors are on the same row in the histology table. This means they can be the same histology or the NOS histology and a synonym of that histology, or an NOS histology and a subtype variant of that histology. M16, abstract a single primary when an in situ tumor is diagnosed after an invasive tumor and tumors occur in the same urinary site. M17, abstract a single primary when an invasive tumor is diagnosed less than or equal to 60 days after an in situ tumor and tumors occur in the same urinary site. Now, we had this same rule in our 2007 NPH rules, so this should be kind of familiar to you. If you have already abstracted the case as an in situ case, you would need to update the behavior to 3. And if the case has been previously reported to the central registry as an in situ or non-invasive case, you would need to notify them of that change. And our last rule, our last multiple primary rule, is abstract a single primary when tumors do not meet any of the above criteria. Use this rule as a last resort. If you've come to M18, make a second pass through the rules to make sure that you have not skipped over a rule that applies to your scenario. So now we're going to move on to histology. You always code the histology diagnosed prior to neoadjuvant treatment. We have a priority list for histology as well as what we did for determining primary site. The priority list is used for single primaries, including multiple tumors abstracted as a single primary. You will code the most specific histology, whether it is from the biopsy or the resection. So our priority order begins here. Remember, you would stop at the first instruction that applies to your scenario. First in priority is you use the pathology from the surgical resection in priority order with addendum first, then final diagnosis, and then last from the CAT protocol. The reason that the addendum is prioritized over the final diagnosis is sometimes there is additional testing done on the tumor that might provide you with a more accurate or specific histology. So that is a priority for determining your histology. Next in priority would be from cytology, which is usually from urine. Third in priority would be the pathology from a metastatic site. Fourth in priority, code the histology documented by the physician when none of the above are available. Use the documentation in following order. So first would be from the treatment plan, then next from the tumor board, next from documentation in the medical record referencing the original pathology, cytology, or scans. And then next would be the physician's reference to the type of cancer in the medical record. And lastly would be from your imaging. Up here in discussing the priority for histology, I want to add for instruction number 1, I don't see it here, but your priority would be first from the op report and next from, the op report from the resection and the path report from the resection, then the next would be the path report from the biopsy. But remember, you always code the most specific, whichever one of those it's from. Coding histology. Again, the priority is to code the most specific histology. Only use this section for one or more histologies within a single tumor. Do not use this section in place of the histology rules. Code the most specific histology, whether it is described as the majority or predominant part of tumor, the minority of tumor, or a component of the tumor. Now pay attention down here to note 1. The terms above, A, B, and C, must describe a carcinoma or sarcoma in order to code a histology described by those terms. For example, when the diagnosis is adenocarcinoma with a clear cell carcinoma component, code clear cell carcinoma 8310. However, if the diagnosis is adenocarcinoma with a clear cell component, you would just code adenocarcinoma 8140 NOS. Do not assume that this is a clear cell carcinoma. This could be clear cell differentiation or clear cell features. So only if your component or minority part of the tumor is described in terms of a carcinoma or sarcoma component would you code that more specific code. Code the histology described as differentiation or features of only when there is a specific ICD-10 code for the NOS with features or NOS with differentiation. Do not code differentiation or features when there is no specific ICD-10 code. Code the specific histology described by ambiguous terms only when A or B is true. A, the histology described by ambiguous terms is the only description that you have that makes the case reportable. The only diagnosis available is one histology term described by ambiguous terminology. For example, if you have a path report and the diagnosis on the path report states suspicious for squamous cell carcinoma, then you're going to code squamous cell carcinoma. However, if your path report's final diagnosis is carcinoma suspicious for squamous cell carcinoma, you're only going to code the carcinoma NOS 8010. The other instance in which you would use the histology described by ambiguous terms is if the physician confirms the histology described by the ambiguous terms, or the patient is receiving treatment based on the specific histology described by ambiguous terms. So this, I just want to comment that this has been something that our abstracting community has had a hard time unlearning. We do not code histologies described by ambiguous terms unless the physician has confirmed the histology described by the ambiguous terms, or the patient is being treated for the histology described by the ambiguous term. And then also only if the tumor described by the ambiguous term is the only term that you have in your medical record that makes the case reportable. So here is our list of reportable ambiguous terms, and these appear in your STOR and SEER manuals. And lastly, do not code histology when described as architecture, configuration, foci, focus, focal, or pattern. So now we are going to move through our H rules. Our single tumor module, H1, code the histology when one histology is present. H2, code oh, and here, as I mentioned before, when I was explaining how to prioritize what documentation to use for your histology, here is in this note 3 is the link for Ask a SEER Registrar. H2, code the invasive histology when in situ and invasive histologies are present in the same tumor. H3, code the subtype variant when there is an NOS and a single subtype variant of that NOS. And here are several examples for you. H4, code mixed small cell carcinoma 8045 when the final diagnosis is any of the following: small cell neuroendocrine mixed with any other type of carcinoma. This does not apply to sarcoma. Or 2 or more subtype variants of small cell neuroendocrine carcinoma, or a subtype variant of small cell neuroendocrine mixed with any other carcinoma. And again, this does not apply to sarcoma. Now, here's a point I want to make here is the reason we have this rule that addresses this histology is because this histology 8045 does not appear in the histology table for the urinary sites chapter. So that is why we have a rule here that is specific to this histology 8045. And H5, code mixed urothelial carcinoma as follows. Code 8120 when urothelial is mixed with adenocarcinoma, squamous cell carcinoma, or any of their subtypes. Code 8130 when papillary urothelial is mixed with adenocarcinoma or squamous cell carcinoma or any of their subtypes. And code 8131/3 when micropapillary is mixed with adenocarcinoma or squamous cell carcinoma or any of their subtypes. So now we go into the multiple tumors abstracted as a single primary. H6, code the histology when only one histology is present in all tumors. H7, code the invasive histology when there are invasive and in situ histologies. They can be mixed in each of the tumors, or they can be in separate tumors. You might have one or more invasive and one or more non-invasive or in situ. H8, code the subtype variant when all multifocal or multicentric tumors are a NOS and a subtype variant of that NOS. And here are several examples. All tumors may be mixed histologies, or one tumor may be an NOS histology and the other tumor may be a subtype variant of that NOS. H9, code mixed small cell carcinoma 8045 when the final diagnosis for all tumors is any of the following: small cell neuroendocrine mixed with any other type of carcinoma, excluding sarcoma, 2 or more subtype variants of small cell neuroendocrine carcinoma, or a subtype variant of small cell neuroendocrine mixed with any other carcinoma, excluding sarcoma. So that is the end of our walkthrough of the solid tumor rules. So I can stop and take a few questions if you like before proceeding to the rest of the presentation.
Good morning. All right, so first question, why does a hyphen make a difference for primary site?
I do not know. And I was going to insert a witty comment in there and say, listen, folks, I don't make the rules, I follow them. And whoever was making the decision on that rule on that day must have been in a picky mood. But no, really seriously, I'm sure that they consulted with their urinary subject matter experts on these, and that was the decision that they were given, and that's why they appear in the rules.
Okay. Will you define contagious or continuous versus non-continuous and discontinuous synchronous versus non-synchronous tumors?
Okay, well, discontiguous is just a multiple tumors that, you know, are not a single tumor. And synchronous would be tumors that occur at the same time. Non-synchronous would be tumors that occur at separate times.
All right. Thank you. Those are the only 2 questions I have so far.
Okay, great. All right, then we'll continue on through the rest of the presentation. Where is it? Here we go. Okay, this is, how do we get out of that? Put you up there. Okay, so we're going to go over the coding guidelines, the SSDIs, extent of disease, and summary stage. So this first slide is all the primary sites of the urinary system and the histologies and the appropriate schema to use for the histology. So I have the link here for SEER RSA, but just want to show you quickly how to navigate to that and how they show us which schema to use for which primary site and histology. So from the home page, the SEER homepage, seer.cancer.gov, you want to hover over registry operations, and then underneath staging, you'll see a link for registry staging assistant. That is SEER RSA. When that page opens up, click on the link to SEER RSA, and then you want to click on View EOD Data, and then your schema list. And then here is the list of all the primary site schemas. So let's look for a second here at kidney, renal, pelvis. So if you click on that, you will see the page that opens up, and here is your notes and instructions that show you which histologies to use for this schema and which primary sites are included in this schema. So in this schema, the primary sites included are renal, pelvis, and ureter. And then here is all your data items, and then you would just click on whatever data item that you are trying to code for the instructions and the codes for that data item. Okay. Coding guidelines. You want to refer to SEER Appendix C, particularly for bladder. And here I've given you the link for SEER Appendix C, but let me show you how to find that. So we want to go back to our home page of the SEER website. I'll just do a new page. seer.cancer.gov. Okay. To get to Appendix C, again, hover over Registry Operations, go to the SEER Program Coding Manual and click there. And then you see a page that opens up where all the appendices for the SEER manual are listed. So you would click on SEER Appendix C, and it is listed, the listing appears by primary site. So we're going to take a look for a second at bladder. So you would open that up, and there you have the coding guidelines, as well as the solid tumor rules and the surgery codes and the EOD schema. for bladder, but we're looking at coding guidelines very briefly. And there you see documentation for coding guidelines for bladder. There's a lot of valuable information there. So I suggest you take a look at it on your own time, but I've covered a little bit of it here in the slides. So our priority order for coding subsites from the coding guidelines is first from the OP report, and then secondly from the PATH report. If the TURB, and for those of you new to the profession, TURB is transurethral resection of bladder. Sometimes you'll also see it abbreviated as TURBT for transurethral resection of bladder tumor. If the TURB or pathology proves invasive tumor in one subsite and in situ tumor in all other involved subsites, code to the subsite involved with invasive tumor. For behavior, we have a little bit of a tough time with behavior in bladder. And one of our very astute editors at the Central Registry noticed some conflicting documentation between the coding guidelines and the instructions in EOD Primary Tumor for bladder. So the instructions from the coding guidelines state code behavior 3, not 2, when the only surgery is TURB, documenting that depth of invasion cannot be measured due to no muscle in the specimen, and the physician T&M is not available, or the path indicates submucosa is invaded, or the path does not mention whether the submucosa is free of tumor or has been invaded by tumor. Now, if you look at the instructions in SEER RSA for bladder, let me get to the schema list for bladder. And we go to EOD Primary Tumor. There's instructions here in note 2 for definitive statements of non-invasion for papillary transitional cell carcinoma and inferred descriptions of non-invasion for papillary transitional cell carcinoma. So one of the descriptions of inferred non-invasion is no statement of invasion, and the microscopic description is present. So their instruction is when you have no statement of invasion, that you are to code that as 000 for papillary, non-invasive papillary, which a code of 000 infers a behavior of 2. So our editor that noticed this discrepancy pointed this out to us. So we sent a question to SEER about that, and they consulted with their urinary pathologist, their subject matter expert. And the response that we got back was, if the diagnosis on the report is high-grade urothelial, and there is no indication if invasive or non-invasive, then code the behavior 3. If, I'm looking down here at the last bullet point on the next slide. However, if the diagnosis on the path report is low-grade urothelial and there's no indication as to whether invasive or non-invasive, then code the behavior 2. Our coding guidelines also instruct us to code the behavior 2 when the T&M designation is TA for a TURB with no muscle in the specimen, or the path indicates submucosa is free of tumor. Here's another new point that we sent a question to SEER about is, how should you code the behavior for urine cytology? As you know, oh, what happened? Let me get back to that slide. So their response back to, I mean, as you know, the behavior should be determined by the depth of invasion of the tumor, and you cannot determine the depth of invasion of the tumor by cytology. So we sent the question to SEER to clarify how we should code behavior of cytology. And there's kind of a long explanation here that you can read on your own later, but basically what they were saying is it's likely that if you have malignant cytology that you're looking at an invasive tumor, as the more aggressive tumors will shed cells into the urine. They would be more likely to do that than the non-invasive tumors. However, based on various studies and papers, cytology itself cannot determine behavior. So the SEER urinary subject matter expert recommends coding urinary cytology as behavior /2 until proven otherwise. So the takeaway is, consider positive cytology as a behavior of 2 until you have a subsequent tissue diagnosis confirming whether the behavior is 2 or 3. Our most common treatments are TURB with fulguration, which would be your electrocautery codes if you see that fulguration is part of that, or with fulguration followed by intravesical BCG, which is Bacillus calmette-guerin. That is an immunotherapy treatment. And this is normally used for patients with multiple tumors or high-risk patients, or fulguration followed by intravesical chemo. We also have photodynamic therapy using laser light and chemotherapy, segmental cystectomy, which is less common, radical cystectomy in patients with extensive or refractory superficial tumor, internal irradiation with or without external beam irradiation, chemotherapy, and immunotherapy. And note that the code for BCG, the immunotherapy, it is to be coded in surgery and immunotherapy. If you're looking through the surgery codes, which you can also access through SEER Appendix C that I showed you a little bit ago, you can see that there is a separate surgery code 16 for this BCG immunotherapy. So moving on to our SSDIs, we don't have very many for the urinary sites. We have our grade, clinical, pathological, and post-therapy, and a schema discriminator 1 for C680 that helps us determine, this is the urethra code. So this helps us determine whether we're to use the urethra NOS schema or the prosthetic urethra schema. So that's all we have for the SSDIs. So going through grade clinical, Jennifer did an outstanding job of going through all that yesterday. So I'm going to try to sort of go through these slides quickly. Remember, the clinical grade must not be blank. You assign the highest grade assessed during the clinical time frame. We do have priority codes for grade. If your histology is a urothelial cancer, your priority codes are the low, high, and 9. If only grade 1 or 3 is documented, then you're going to have to code that as 9. If the histology is an adenocarcinoma or a squamous cell, the priority codes are 1 through 3 and 9. If only L or H is documented, you're going to code as 9. And this will be the same instruction for grade pathological and grade post-therapy. Grade 3 also includes undifferentiated and anaplastic. A TURB qualifies for a clinical grade only. Grade 9, when no grade documented, clinical workup not done, or grade marked not applicable on CAP. If there is only one grade documented and you don't know if it's clinical, pathological, or post-therapy, you will code as clinical. Grade pathological. Grade pathological cannot be blank. And remember, if your highest grade is from the clinical workup, you're going to assign the clinical as both your clinical and pathological grade. If a resection is done of the primary tumor and there is no grade documented from the surgical resection, use the grade from the clinical workup. If a resection is done and there is no residual cancer, use the grade from the clinical workup. And then same instructions for the priority codes for urothelial versus adenocarcinoma and squamous cell carcinoma. The TURB does not meet the criteria for grade pathological. You must have at least a partial cystectomy to meet the criteria for pathological grading and staging. Code 9, when the grade is not documented, no resection of primary site, neoadjuvant therapy followed by resection, clinical case only one grade is given and you don't know if it's clinical, pathological, or post-therapy, or the grade is marked not applicable on the CAP. Grade post-therapy is left blank unless this is a neoadjuvant case followed by surgical resection. And remember, if there's no assign the highest grade from the resected primary tumor assessed after completion of neoadjuvant therapy. Same priority codes for urothelial versus adenocarcinoma. So the same instructions apply from the grade clinical and pathological. Those apply here as well. Code 9, when surgical resection is done after neoadjuvant therapy and the grade is not documented, or surgical resection after neoadjuvant therapy and no residual, or marked not applicable on the CAP. So now we're going to move into EOD, and there's a lot of words on this slide. So I'm gonna, since we're getting short on time and I wanna have time for questions, this first bullet point is just describing the differences between your flat and papillary types of transitional cell carcinoma. So you can read through that. And then I already showed you in CRSA in note 2, the terms for definitive non-invasive papillary transitional cell carcinoma versus the inferred terms for non-invasive papillary transitional cells. So those would be included in code 000. Code 050 is for the in situ non-papillary transitional cell carcinomas, just your AD120s. Non-invasive in situ flat transitional cell carcinoma, careful attention must be given to the use of the term confined to the mucosa. For flat bladder carcinomas, these are your AD120s, in order to accurately code tumor described as confined to the mucosa, the abstractor should determine if the tumor is confined to the epithelium, then it is non-invasive, 000. If the tumor has penetrated the basement membrane to invade the lamina propria, then it is invasive and coded to 100 for localized. If the distinction between involvement of the epithelium and lamina propria cannot be made, then the tumor should be coded as confined to the mucosa NOS. Terms synonymous for confined to the mucosa include confined to the mucosal surface, superficial NOS, limited to the mucosa, no invasion of submucosa and muscularis, and no invasion or infiltration of the fibromuscular and muscular stroma. EOD,
So Robin,
yes.
I hate to do this to you, but this presentation is over at 10. Your Friday presentation is until 10:30.
Correct.
So we are actually at time.
Okay. Well, all right. Well, okay. You need me to stop?
Well, the thing is, we want to respect people's time, so we'll go for at least another 5 minutes, maybe 10. But I know I personally have to go, and we did schedule this from 9 to 10 Eastern.
Okay. Well, I'll just continue. I think I can finish these slides in 5 to 10 minutes. And I'm also willing to stay on if anybody has any questions. And those of you that need to leave, we certainly do understand that. So going on, is that okay?
All right. At 10 after, we're going to have to close this.
Okie doke. So EOD primary tumor, bladder, code 300. If the only description of extension is through the full thickness of the bladder wall and there is no clear statement as to whether or not the cancer has extended into fat, code 300. These other instructions in these bullet points, I'm going to leave you to those on your own, but they basically say that when you're coding invasion, when you have bladder that's extended to the ureter or the urethra, you want to code the invasion based on the depth of invasion and not to the extent of the neighboring organ. Renal, pelvis, and ureter. In case of multifocal, non-invasive, and in situ tumors, code 050. And again, the depth of invasion is our second bullet point and our third bullet point. The prostatic urethra in case of multifocal non-invasive and in situ, code the 050, the in situ code. This note does not appear in the instructions for your urethra, but assume the same. The urinary other just has a common sense note. If the primary tumor is 000, behavior must be 2. If extent is 100 or greater, then behavior must be 3. The EOD regional nodes, the regional nodes are listed here. 300 for bladder, for 300 for a single node, excluding common iliac, 400 for multiple nodes, excluding common iliac, and 700 is your code that includes the common iliacs with or without other regional nodes. Now notice that common iliac is regional for EOD, but distant for summary stage. Our regional nodes for pelvis and ureter are again listed here. We have a size criteria for our codes 200, 300, and 400. 200 single node less or equal to 2 centimeter, 300 single node greater than 2 centimeter, and 400 multiple nodes. Here is our codes for the regional nodes for urethra and prostatic urethra. Our 300 is single node, 400 is multiple nodes. And then our regional node listings for the others, the C681 and C688 through 689. We have the regional nodes, and there's no criteria code for lymph node size or whether single or multiple nodes. The EOD METS codes are easy because they're the same for all the sites. Code 10 is distant nodes, and code 70 for all other metastatic combinations. Our summary stage, be sure you refer to your site-specific schemas, read the schemas, and do not rely on your memory. Be aware that some sites that are not considered metastatic can be distant for summary stage. For example, the common iliac nodes in bladder are regional for extent of disease, but distant for summary stage. And the good thing is if you are coding EOD, then that will derive summary stage. And that's the end. My little graphic here is a yellow waterfall to represent our urinary sites. And an interesting factoid is that I live on Jackson Lake here in Georgia, and the Yellow River is one of the main rivers that flows into Jackson Lake all the way down from Gwinnett County. So do we have any questions?
Yes. Well, it's not a question. It just says, can you re-show where you went to SEER.gov and found the coding manual? Whenever I open up the SEER website and hover over registry operations, all I see is registry assist, SS 2018, EOD 18, the staging resources.
Sure, I'll be happy to. Okay, so go to the SEER website, seer.cancer.gov. Sometimes I think, you know, one of the hardest things about abstracting is knowing where to find everything. And once you know where to find everything, that really makes your job so much easier. So here, if you just hover over registry operations, don't click on it, just hover over it. And then you should see a drop down that opens up with different categories. You have reporting guidelines, tools and softwares, questions and answers, staging and training. You want to go to the reporting guidelines category. Let's see what happens if you just click. Okay, yeah, just go on under the reporting guidelines category, click on the SEER program coding manual, and there you go. If you have an older case and you need to look at an older SEER manual and, you know, their appendices and staging and all that, there's a section over here for historic staging and coding manuals where you can click on that and get that information there.
Okay. That's all the questions I have. I don't see any more popping up.
Okay, great. Just a plug, I'm going to be talking about central nervous system malignancies on Friday, and later today you will be receiving a case scenario that we're going to go over at the end of the presentation. So if you get a chance, take a look at that, because we will be talking about that after the presentation on Friday.
Okay, for those who are GATRA members, we'll be doing our virtual installation of officers at 12 noon. And we'll be also drawing for a $25 e-gift Amazon card for those who did vote for your elected officers. So we'll be doing that at noon. And so we'll see you at noon if you're a GATRA member. And others, we'll see you at 2 o'clock this afternoon. Thank you.
Thank you, everybody.